Okay.
Right. Well, I'll start. Thanks ever so much for bearing with me. As I said, I'm Nikki Derrick. I'm one of the occupational therapists in the Integrated Community Stroke Service, which is essentially the community stroke team. I work in North Somerset. And yeah, I'm going to be presenting to you about visual issues after stroke. So I hope you find this interesting. Any questions, feel free to fire away afterwards. We've got quite a lot to crack through, so I'll make a start. It's always good to, when we're talking of visual issues, just to remind ourselves how the eye works. Actually, how do we actually see a visual image? So to understand the visual system, we need to think really that there's four parts to seeing a visual image. It's your eyes taking in the light rays. It's your brain interpreting and making sense of them. And within the brain, that will be controlling the muscular control of the eyes. That'll be the visual pathway, so getting the information all the way to the area that processes the light, the electrical impulses, and then it's perceiving the image, making it meaningful to the person that's viewing it. So if we start with the eye, then at the front of the eye, we've got the cornea. That's the transparent bulge. That's the sort of the front line of defense of the eye. So if there's any dust particles or dirt or anything, the cornea will hopefully bat that away. But it's essentially it's transparent so that light can enter the eye through the cornea. Um, it's also a barrier to some of the more harmful UV lights as well. It's a curved surface so that the light can bend towards the retina as well. We've got the iris, which is the coloured part of the eye. So if we say we've got blue eyes, really we mean we've got blue irises. It's made of muscles which constrict or dilate the pupil to let more or light or less light in. And the pupil at the center then of the iris is essentially just a hole. So light comes through the cornea, through the iris, and at the lens, there's muscles in the lens to alter the shape of the lens, allowing focus. So if we need to focus on something that's closer to us or something that's further away from us, it's the lens that controls that. And it's the lens that loses that flexibility as we age. So that's why we find it harder to focus on something closer as we get to older age. um, it's also a transparent disc as well because it needs to let light through. So the light comes through the cornea, and at the lens, it's refracted or bent onto the retina. So light is coming all the way, and at the sort of right at the back of our eye is the retina. The retina covers a large surface area of the back of the eye, and it's here where the light signals are converted into electrical signals. So it's actually part of the central nervous system, the retina, because it's where electrical signals start from. Within the retina, we've got lots of photoreceptor cells, and they are the cells that are responsible for changing the light signals that are coming into the eye into electrical signals and electrical impulses, which the brain can then use to interpret the visual scene. And within those photoreceptors, we've got cones and rods. And cone cells are responsible for seeing the color and the detail of an object. And rods are more sensitive to light. So we'll find that in low light levels, a lot of our rods are activated. But in good light levels, if we're needing to see something in good visual acuity, it's the cones that are activated. And most of the retina surface, most of those photoreceptors are actually rods, but in a particular very, very small, minute area within the retina called the macula, we've got a much greater percentage of cones. And this is where we need our light rays to be refracted on, so that if we're seeing something very that we need good detail, good visual acuity for, then the light will go towards, be bent and refracted towards the macula. And there's a point within that macula, tiny little dot called the fovea, and there is only cones there. It's only cones. There's no rods at all. And so that helps us to make sense of maybe macular degeneration or something, because that's the spot there where there are, really just a very high percentage of cones. And so that's the area that can be degenerate as we get older sometimes. And so it's difficult for us to see detail, that visual acuity, that central vision. So the electrical signals are made at the retina, and they need to pass through the eye towards the rest of the brain. And they do this via a bundle of nerve fibers that leave the very back of the eye via the optic nerve. And you'll see that where there is the space for the optic nerve to come through, there is no retina. So there's no photoreceptor cells, and therefore that's our blind spot, because there's, if light was to be bent onto that area of the retina, there would be no cones or rods or photoreceptor cells to transfer that light signal into an electrical impulse. So that's the start of the journey. Light is essentially coming through the eye, and the retina is converting those light signals into electrical impulses. So what happens once it leaves the eye and the optic nerve? Well, those electrical impulses are taken via the optic nerve to the back of the brain. And the electrical signals are taken through to an area in the thalamus, which is essentially a sensory relay station, and that's called the lateral geniculate nucleus, but just think of that as an area in the sensory relay station of the brain. And from there, the electrical signals are taken to the very, very back of the brain in the occipital lobe. And that's where the primary visual cortex is. So all electrical signals need to go from the back of the eye to the visual cortex to be interpreted as a visual image. And I'll just show that in another slide, just so it's a little bit more easy to see. Perhaps we can see that the eye here, there's the retina at the back. The electrical signals are taken via the optic nerve. Now, this is a little bit more easy to see in this slide, what essentially called the optic chiasm, but it's really a cross in the brain where signals go, they may stay on one side of the brain, or they may be taken to the other side, the contralateral side of the brain, and that will become important in a couple of slides as we go on. But half of the electrical impulses will stay on the same side of the brain and be processed in the visual cortex and occipital lobe right at the back of the brain on the same side. But half of them will cross over to the other side of the brain. And you can see hopefully in this slide that we can see that actually the electrical signals need to be transported right from the very front of the brain where the eyes are all the way to the very back of the brain. So it's a large pathway is the visual cortex. Now, that's not the end of what happens to vision, because the visual image is interpreted. It's been made from an electrical signal and turned into a visual image, but the brain needs to process that further. And so that image is relayed to different areas of the brain for further interpretation. So we do have the dorsal stream, which is taking that visual image to the parietal lobe within the brain, and that's interpreting the where aspect, where that object is in space, for instance. And then we have the ventral stream, which takes that visual image to the temporal lobe, and that processes it as what is that image. It identifies that visual image and recognizes it from our memory. So again, this is just showing that actually a lot of the brain is taken up with interpreting and making sense of this visual image. So how do the eyes move, and what part of the brain makes that happen? So there's a lot of muscles in the eye, and there's muscles on the external part of the eye that controls the movement. So there's loads and loads of sets of muscles in and around the eye which are needed to stabilize the eye. So when we're gazing at something, it keeps it still. To alter the shape of the lens, allowing us to focus on an object. To constrict and dilate the iris, to alter the pupil size, to allow us to watch a game of tennis or follow an object around the room in those sort of smooth, coordinated movements. So there's lots and lots of muscles that are required to move the eye, or indeed to keep it still. And if a stroke has disrupted the nerve supply to these muscles, then that's going to result in visual problems. And if I show you in the next slide, the movement of the eye muscles is mainly coordinated by the cerebellum and the brainstem at the base of our brain. And they are very integral to movement. And so if there was to be a stroke that affected the brainstem or the cerebellum, then the movement of the eyes may also be affected. But you can see that all these areas of the brain, these are the main areas of the cerebral cortex here. Every one of those is involved in vision in some shape or form. So the frontal lobe, the orange lobe here, right at the front of our brains, that's more involved in the higher coordination of the eye movements. The temporal lobe, which I mentioned earlier with the ventral stream, that's involved with identifying and recognizing the image. What is the image? We've got the parietal lobe in blue here, and that perceives the objects in terms of whether it's moving, where it is in space, the location of it, and so on. And the main area that a lot of people are familiar with for processing the visual image is the occipital lobe. But that's right at the back of the brain, and that's where electrical signals are turned into visual images. So all of the signals that are coming in from the eye need to be taken to the occipital lobe to be turned into a visual image. So we can see that there's a huge amount of the brain that's involved in vision. And so it's not surprising at all that after a stroke, vision is often something that people find they have an issue with. There is an impairment in their vision. And actually the latest guidelines from the Royal College of Physicians suggest that nearly 60% of people after a stroke may have some degree of visual issue or visual impairment afterwards. And I think it just shows here when we're looking at the brain and how many areas of the brain are involved in vision, then that makes sense, because it's almost doesn't really matter where the stroke is, there could be an issue with vision. Now, I was just going to touch on two of the most common visual issues that we might see after stroke, but there are many. But one of the most common is hemianopia. And hemianopia is when there's half of a visual field is missing, and that could be in the right half or in the left half. If we break down the word hemianopia, hemi meaning half, and anopia meaning no vision, it's half of no vision. The image that we've got on the left of the screen here, that's an image of a train station near to where I live, and it's just a photo of what someone might see in their visual field. So if anyone without any visual defect or eye condition was to look straight ahead of them, this is the image that they would see in their visual field. But if they were to have hemianopia, and right-sided hemianopia I'm talking about now, then they wouldn't be able to see half of that. So if you were to draw a line down that, the right-hand half would be something that they wouldn't be able to see. And that's depicted in the picture on the top right of the screen. So essentially for this person with right-sided hemianopia, they wouldn't be able to see the train tracks, for instance, or the yellow line informing them not to go too close to the train tracks. That's the image that we see a lot in books, or if you were to do a Google search or something, it's a big black space in our visual image. And I think that's misleading because it makes us think that actually maybe the person can see a big black line down their vision, and they realize that they can't see half of it because it's a big black area. But actually, that's not the way that patients tell us they can see. Just like if we know that we can't see the back of our eyes, we know at the back of our head we can't see anything behind us, but we don't perceive that as a big black area. We just can't see it. And so this is how people with a hemianopia would see the world. They don't see a big black space. It's just that what they see is what they assume is their entire visual field. It's just there. And so I think this helps to make sense of the fact that sometimes if someone is suffering from a visual field loss like this, it's really important that we explain and educate to the patient what is happening, to make it really very apparent that it's actually half of their visual field that is missing, and so they do need to learn strategies to compensate for that. But why is hemianopia? Why does that happen, and how does that happen, and what happens in the brain to lead to that? So if we have a little bit of a look at the visual pathway, again, we've seen a couple of slides, but this is in further detail. Stick with me because hopefully it will make sense of it. So I'm going to be using the terms temporal field of vision and nasal field of vision. So the nasal field of vision is that field of vision closest to the nose, so in the inside part of our vision. And the temporal field of vision is that vision that's to the outside of our field of vision. So if I'm thinking of in the right eye, the temporal field of vision would be to the right-hand side, and the left-hand side of that field of vision would be closer to the nose. So if we're looking at the right eye, light rays that enter from our nasal field of vision will come in. They'll come in through the cornea, and the lens will refract that light onto the back of the eye towards the retina. But it's actually the retina is on the other side, so the temporal side that takes in the light rays. And so those light rays are taken in and turned into electrical signals, where they are transported via the optic nerve. Remember that point that crosses called the optic chiasm? Well, they stay on the same side of the brain, taken down to the sensory relay station in the thalamus, taken all the way down to the occipital lobe, where they're turned into visual images. So that's quite straightforward, hopefully. So light that enters our nasal side of our field of vision is processed on the same side of the brain. Well, if we look on the temporal side of vision in the right eye, so that's light that's coming in from our outside, some of the right-hand side of our right eye, the light is taken in and is turned into electrical signals in the other side of the retina, on the opposite side within the right eye, the nasal side of the retina. And that is turned into electrical signals, which are transported via the optic nerve. And at the optic chiasm, they swap over to the other side of the brain, and they carry on via the optic tract, are taken to the sensory relay station, and they're processed by the visual cortex and turned into visual images. So information and light rays that are coming from our temporal field of vision, so in our right eye, that's on our right-hand side, are taken to the opposite side of the brain. And the same goes for the other eye. So if we have a look at how hemianopia comes about, hopefully this will make a little bit more sense of it. So in this diagram, we're going to look at left homonymous hemianopia, which means that the field of vision on the left-hand side is missing. Now, hemianopia, you may remember I said if we split that word, hemi is half and nopia is no vision, so half of no vision. But homonymous hemianopia is the same half of no vision. So it means for this person with left homonymous hemianopia, we have the left side of the left eye, so the left field of vision in the left eye is missing, and the left field of vision in the right eye is missing. So it's on the same side for both eyes. And this is a really common visual impairment after stroke. It can be left, it can be right side. They're both common, but for the purposes of this diagram, this is left homonymous hemianopia. So if we look at what's happening, we can see that there's a disruption here at point C, and that's where the optic tract is taking those electrical signals towards the back of the brain for processing. So the electrical signals can't get through at this point. There is a disruption here, and there's no way those signals are going to get through. So if we work up and at the start of the journey, the light rays are entering our eye from the nasal field of vision. They're entering our eye, and on the temporal retina, they're being turned into electrical signals. Those electrical signals are being transported at the optic chiasm here, that crossing point. They are carrying on the same side of the brain. But at this point here, where there's been a stroke that's affected the blood supply to this area of the brain, they're not going any further. And so therefore, those electrical signals can't be taken to the occipital lobe for processing. So although the eye is working, it's doing its job, it's taking in the light, it's turning the light signals into electrical signals, and it's being transported to the brain, it's not getting far enough through that visual pathway to get to the occipital lobe. And so we can see from the nasal field of vision here in the right eye, then we're not going to get any visual information at all. So that's why there is no vision on the left side of the right eye. So what happens to the other eye? Well, if we follow this up, we'll see that light is entering our left eye. The light that's entering from our temporal field of vision in our left eye is coming into the eye. The lens is refracting it to the back of our eye at the retina, and the retina here on the nasal side of the retina is turning that light signal into an electrical signal, and it's being transported down the optic nerve and up the optic chiasm. It's crossing to the other side of the brain, and it's continuing its journey. But unfortunately, because of the blockage here, it's not getting through to the back of the brain in order to reach the occipital lobe to be turned into a visual image. And so therefore, we're going to have no image at all. And that's on the left side of the left eye. So that's the temporal side, which is why the left side of the left eye, there is no vision there. So we can see how we end up with the visual impairment known as homonymous hemianopia, because it's the same side of field of vision that's missing in both eyes. And hopefully this has explained a little bit about how the visual pathway works and why this would happen. I think it's really useful to understand, because for a lot of people with homonymous hemianopia, they do believe that it's just one eye that's affected, you could understand that if you were suffering from the loss of field of vision on your left side in both eyes, you might think that it's just the left eye that is affected. But it's, as you can see here, it's not the left eye that's affected. It's half of the left eye's field of vision that's affected and half of the right eye's field of vision that's affected. So I hope that makes a little bit of sense. Another one of the more common visual issues after stroke is called diplopia, which is double vision. And that's when you look at an object, but you can see two images. Some people report horizontal diplopia, where the image is to the side of each other, and some people report vertical diplopia, which is an image on top of each other. We're binocular creatures. We need to see the same image in both eyes if we're to get a clear single image. And so if there's an issue with the way the eyes are working, the muscles in one of the eyes working or looking at a visual image, we might end up with issue of double vision. It's a very uncomfortable impairment for somebody, but it's usually remedied by the person closing one of their eyes, and then usually that diplopia is resolved momentarily. So it may be that someone with diplopia finds the use of an eye patch useful, for instance. So how does a vision impairment after stroke get identified, and what can be done? So anyone who has had a recent stroke should have a vision screen carried out. Often this is done on the ward, but if it's not done on the ward, it can be done in the community, and it's quite often done by an occupational therapist. It is just a screen that takes no longer than 10 minutes, but that screen is looking at visual acuity, visual field, and asking questions such as whether someone might be suffering from double vision or blurred vision or visual hallucinations, for instance. Anyone that is identified as having a new visual issue after their stroke is referred to an orthoptist at the eye hospital, and the orthoptists run clinic at Bristol Eye Hospital and Western General Hospital as well. The referrals go to the orthoptist specifically within the eye clinics because it's the orthoptists that specialise in eye movement disorders. So they'll receive any referral from someone that's got a visual issue after a stroke. And it's the orthoptist that can diagnose the actual condition. So they can diagnose as to whether someone has left homonymous hemianopia, for instance, and they can give practical, they can talk about practical issues such as whether driving is possible for someone, whether prisms in spectacles might be useful, whether someone's sight impairment is significant enough to be registered as being sight impaired or severely sight impaired, and also strategies. And alongside of that, if someone is receiving therapy as part of rehabilitation, then there's approaches and treatments that can be looked at. So if someone has hemianopia, so that visual field loss, then one of the major treatment approaches we would be using as therapists would be to look at scanning techniques. So if you recall that photo of someone looking at the train station, and half of their visual field was missing to the right-hand side, then we would be wanting that patient to be learning the scanning technique of moving their eyes, moving their head in a systematic way to the left and to the right to make sure they're getting in all of the image that they need to see. If there's half of a visual field that's missing, the person needs to learn the technique of scanning to that side so that they can move their head and turn and receive all of that visual image. So that's a lot of the techniques that we will be practicing in our treatment. Is encouraging a person to look to the left and the right in a systematic way to ensure that they don't miss anything in their visual field. We'll also be looking at eye search exercises and computer-based programs, which are restorative treatment approaches, really. It's helping to improve a person's visual function by inducing changes to how they move their eyes to look at the world around them. It won't actually improve the visual field loss, but it could make life easier for a person to manage. And eye search therapy, there's a couple of programs on the internet that are free. And we might be looking at that as a way of therapy. So it's exercising the part of the brain that controls eye movement, which may help to find objects in a crowded room or so on. So although these therapy approaches aren't going to remedy the problem or the issue, it's hoping that by repetition and practice that a person can manage better in their everyday life by learning how to move their eyes to look at the world around them. And we will always be directing anyone with a visual impairment to other areas of sight loss support as well. So in North Somerset, we have Vision North Somerset, who are a sight loss organisation based in Weston-super-Mare. Nationally, there is the RNIB. And then for those that live in Bristol, South Gloss, Bath and areas around, then there is Sight Support West of England. And these organisations are absolutely brilliant in providing advice and practical aids and techniques to someone with sight loss. For instance, they may look at aids such as the liquid level indicator, putting on bump-ons, for instance, bright coloured dots around the home. The rehabilitation officer for the visually impaired may be looking at providing long cane training for someone if mobility is an issue after their visual impairment. And there's all sorts of talking gadgets out there, for instance, a talking watch or talking scales or what have you. And these organisations will be able to offer lots of advice to a person with a visual impairment or a visual issue after stroke to help them remain independent and safe. So that's a vital piece of support for people in the community. So that's been a little bit of a whistle-stop tour. I think what I will do is stop sharing, and then if there's any questions,